Joseph, can you just click on your screen that people can see me?
Okay.
Okay, thank you. Dear ESTS members and webinar attendees, my name is Lieve Piepere, your moderator for today. I hope you enjoyed our first ESTS e-conference last week, and I hope you are ready for the third season of our webinars. This year, we are going to be even more interactive than we already were last year. And we will start with the first webinar being a multidisciplinary case discussion on lung cancer. I'm very proud to introduce you to our fabulous expert panel of today. Our medical oncologist today is Professor Solange Peters. She is the lead of the medical oncology in Lausanne, Switzerland, and the co-chair of the Swiss Lung Cancer Research Group. She's also the current president of the European Society of Medical Oncology, ESMO, and one of her main research interests are focused on the multimodality curative intent treatment of stage 3 non-small cell lung cancer. Our radiation oncologist today is Professor Esther Troost. She is the co-chair of the Department of Radiotherapy and Radiation Oncology of the University Hospital and Faculty of Medicine of the Technische Universiteit Dresden. She is also a member of the EORTC Radiation Oncology Group and European Thoracic Oncology Group, ETOP. And the last expert is our surgical expert, Professor Jozsef Furak. He's the head of the Department of Thoracic Surgery at the University of Szeged, Hungary, and one of his favorite research topics is also on lung cancer. So now I will start presenting the first case. We will ask the audience some questions during the presentation, and thereafter the expert panel will discuss the case. Our questions for the audience will appear in the polls section, which is the second section in the sidebar at your right-hand side. And you can also ask questions to the expert panel in the questions section, and that's the first section in the sidebar at your right-hand side. So I hope everything is clear, and then we can start with the first case. This case was provided by Dr. Nuria Nuvoa from Salamanca. She is our knowledge track coordinator from the ESTS. So I go to the first case now. I hope everyone can see that one. First case, a male patient of 68 years old, former smoker with 35 pack years, arterial hypertension, and a normal respiratory function, as you can see. The initial CT study showed a lesion in the right lower lobe, 1.7 centimeters in diameter, and one lymph node of 0.5 centimeter, it's not millimeter, in its shortest diameter. And then another one subcarinal of 1.3 centimeters. There was also a PET-CT, and the PET-CT showed that this lesion had an SUV max of almost 6, and the subcarinal lymph node had an SUV max of 4. There was no brain MRI performed, and the patient was asymptomatic. So CT findings T1B in 2 because of this subcarinal lymph node, and the PET-CT findings T1B in 1 and in 2. EBUS were performed. Station 4 right was negative. Station 7 was also negative. The first question, should we proceed to mediastinoscopy, direct lung resection with direct lung resection with systematic lymphadenectomy? I see that there seems to be a problem. No one can see the slides? Because I can also not hear you. Okay. I'm very sorry. Then I'll try to do this again. What happens?
Mm-hmm.
Okay, can we see it now? Okay, great. So you already heard the case, and I can go a little bit faster on it. So the lesion, you can see it here. 1.7 centimeters right lower lobe. Lymph node right. Lymph node subcarinal. And then the PET-CT lesion of SUV max of 6. And the subcarinal lymph node was an SUV max of 4. No brain imaging. And the staging with EBUS and EOS was negative. So our first poll, our first question, you can answer on this right now. How should we proceed? Mediastinoscopy or direct lung resection plus systematic lymphadenectomy? You can vote. I'll let you vote for, let's say, 20 seconds, and then we can go on. There's almost 100 people in the room, so we can definitely have some more interaction. We cannot see what you voted, so don't be afraid. Okay, now we have around 30% mediastinoscopy and 70% direct lung resection and systematic lymphadenectomy. Let's see what the surgeons did in this case, and then we can discuss this afterwards. Our decision was VATS right lower lobectomy plus systematic lymphadenectomy. And the idea was, first, we were not expecting bulky in-2 disease because of the CT findings. Second, only expecting in-2 positive single station at the subcarinal lymph region because of the CT and the PET combined. The right lower lobectomy is the surgical procedure because of the young patient plus a good respiratory values and a good control of the primary tumor. And systematic lymph nodes dissection is the best possible lymph nodes. Systematic lymph node, the best possible lymph node ipsilateral evaluation compared to the mediastinoscopy or EBUS. So then we have a good idea of all the lymph nodes resected in the same procedure. Postoperative findings, there were no postoperative complications. Respiratory functional parameters, as you can see, an FEV1 of 88%, DLCO 73. It was a squamous cell carcinoma, TTF1 positive, station 4 right and 7 contained no malignant cells. So it was a PT1B, PN1, M0, R0, stage 2B. Should we proceed to observation versus adjuvant treatment? Maybe we first answer this question. You can go to polls and answer this one. No, it goes already a little bit faster. That's good because we're gonna ask you a lot of questions. Okay, and this is 10% observation and 90% adjuvant treatment. Okay, let's say we give adjuvant treatment. What kind of adjuvant treatment do we give then? Chemotherapy, radiotherapy or concomitant chemoradiotherapy. A lot of people go for chemotherapy, and only a few for radiotherapy or concomitant chemoradiotherapy. Okay. So this patient got cisplatin-based chemotherapy 3 times, and the patient is alive with no signs of recurrence at 30 months. Okay, thank you for your collaboration in the audience. I'm sorry for the problem with the screen in the beginning, but I hope we can have the first discussion now. I invite already 2 of our experts to the stage. And I see that Professor Furak is...
Okay. Hello, everybody.
Okay, perfect. Oh, we can see the slides.
Is it good?
It's perfect.
Super. So after the clinical presentation, we have to conclude that we can conclude that we have a cancer, stage 3A and 2. You can see here it's 70 millimeter, and in 1 station, so the single station and 2 subcarinal lymph node is larger than 1 centimeter. At the time, we know that the CT sensitivity is not so high, specificity is low. On the basis of the guidelines that we can find in the literature, we have to do or recommended to do a PET-CT as a preoperative staging. So as the team performed the PET-CT, it's very nice and we know it. And I would like to give the microphone to Esther.
Thank you, Jozsef. Then you have to click for me, please.
Yeah, sure.
Because it doesn't work. So I really wanted to focus briefly on the value of the PET-CT scan, not only for staging in this purpose, but also for radiation treatment planning. So maybe it's from the order, it could also be a bit later, but I think even though now it's worthwhile to have this already on stage. For the primary tumor and also for lymph nodes, especially in stage 3 cancer, lung cancer patients, non-small cell and also small cell. But in this study, all of those were non-small cell. A Dutch team compared the value of both CT scan and the value of FDG PET scan for target volume delineation. And this also prompts us to find our positive lymph nodes when looking into the preoperative staging. And as you can see here, there's a large inter-observer variation if you only look into the CT scan, but if you look into PET, and you can click again, that's the lower row, so the B pictures. If you, Jozsef, if you click again, you see that the standard deviation of about 10 millimeters reduces to 5 millimeters. If you take the next slide. Yes, so you really see that we are more accurate in delineating as radiation oncologists what our target is. And this for the primary tumor is not only true for the, let's say, for the more central ones, but obviously also for the tumors that are amidst the lung, and of particular value if there is atelectasis or if there is mediastinal invasion of tumors, so more the advanced stages. The reason why I looked into this is also the selective nodal irradiation, and this is also largely based on the value that we have of the PET-CT staging. Selective nodal irradiation is really what we do nowadays. So we don't treat the entire mediastinum to a dose of about 50 gray, but we really selectively do nodal irradiation to the positive lymph nodes, and these can be, and this is being alluded to later on by Jozsef, it can be both based on imaging and obviously, if possible, also of confirmation. So what we would do is, in this particular patient, really look into lymph node station 7 to see whether this is affected or not, to guide our treatment decision. if you go one back, sorry, this was a bit too fast. In the 3D era, we saw that there's only a very low incidence of nodal recurrence, only of 2.3%. So it's safe to do PET-CT-based selective nodal irradiation. And now you can move on. Thank you. And we prompted, or the question was whether this was still valid in the era of intensity modulated radiation therapy. And this is being alluded to in the next slide. Also it has been validated in a large cohort of almost 200 non-small cell lung cancer patients with a long follow-up. And of those, 62% suffering from recurrent disease, you can again see, next click, that only the isolated nodal recurrence rate was again 2.2% as opposed to 2.3 on the previous study. So this is a very good concept to move forward. Next slide. I think it's you. Yes, one very important topic for those maybe among students are radiation oncologists. Please be aware that for CT, we really use fixed lung and soft tissue window level settings. And it can be challenging for CT because of atelectasis, effusions, the nodal involvement, as you saw in this patient, there's a low sensitivity and also a rather low specificity. And movement can be of influence on the CT. But especially in PET imaging, we have to be careful what window level setting to use, because it's a very flexible imaging modality, so you can make your target volume as large as you like. And it's also, the challenges are inflammation, the low resolution, and also movement that affect the PET signal.
And what do we know after the PET-CT? So it is discussed. So right now we know we have a T1B, N1 and N2 on the basis of the PET-CT. And we arrived to the crossroad, what to do, as we asked upfront surgery on invasive mediastinal staging for this 3A station. It is recommended by these guidelines, one of the ESMO, the other one is the ESTS guideline, that invasive mediastinal stage is indicated in case of positive PET-CT positive N2 lymph node cases. And if the lymph node in the mediastinum negative, but the primary tumor is larger than 3 centimeters or located in the central part of the lung, 1/3 in the lung, or you have a clinical suspicion for the N1 disease, or the negative lymph node on the PET-CT is larger than 1 centimeter in the small axis, we have to do, or the invasive mediastinal staging is recommended. Why? Because in that case, the chance or the risk for the metastasis in the lymph node is very high. But otherwise, in contrary for that one, in stage 1 lung cancer cases, the risk for the N2 metastasis is only 3%. So by the recommendation of the ESTS guideline, there are two possibilities or to do the invasive mediastinal lymph node staging. One is the EBUS-EUS or video mediastinoscopy. So in that case, they performed the EBUS-EUS, that was negative. But we can see here that the sensitivity or the specificity, but mainly the sensitivity of the EBUS-EUS is not 100, it's around between 80 or 83, 93%. So it's not 100%. So the chance for the negative case is not so high, but not we cannot be sure enough. And after this negative PET-CT, I mean positive PET-CT and negative EBUS-EUS, what to do? Currently, we excluded with the EBUS the N2, but otherwise we know that the chance or the risk for the N2 metastasis is about 80%. Now, of course, we know that it's in single N2. What to do? Go to the surgery line or mediastinoscopy. By the recommendation of the ERS and written by Ramon Ramiporta, in negative EBUS-EUS cases, the mediastinoscopy is recommended. So we should modify the ESTS guideline or this flowchart, EBUS, EUS, and mediastinoscopy. So if we do the mediastinoscopy as an invasive mediastinal staging, we should take a biopsy for level L both sides, for both sides, and in station 7. Or the other possibility is the well-known TEMLA and VOMLA and TEMLA. We know that these procedures are performed mainly in centers. You can see here the big names of this investigation, and it is indicated as a primary investigation, invasive mediastinal lymph node staging, or re-staging after neoadjuvant treatment also. Mainly indicated this procedure in central tumors, clinical N1, and when the tumor is higher than 3 centimeters. And we didn't speak about the brain metastasis screening by the guidelines. The MRI recommended for the brain metastasis exclusion to exclude because the PET-CT sensitivity is very low. If it's fine, the specificity is high, but because of this low sensitivity, the brain MRI is recommended. So I think we discussed the invasive mediastinal staging, and we can decide what to do after on the basis of this result. And we should something speak about the upfront surgery, because as we heard, lots of you would do this kind of way. About the upfront surgery, there is a nice paper presented with Eric Lim and co-authors, big names and very respected experts in the thoracic field. And it stated that invasive mediastinal staging is irrelevant, no relevant. So irrelevant for PET-CT positive N2 cases if the primary tumor and the ipsilateral lymph nodes are resectable. How can they support this statement? If we perform an invasive mediastinal node staging in case of positive PET-CT in resectable cases, the concept would be negative selection. The patient could be excluded from the surgery, and this statement or this investigation supported mainly the medical recommendation treatment, oncological treatment. And they performed meta-analysis, 6 randomized trial compare the surgery plus chemotherapy versus chemoradiotherapy, and they did not find, they found that no evidence in failure of non-surgical management, and the overall survival was favor on surgery. So on the basis of this statement, they stated that the clinical investigation for mediastinal lymph node staging should be stopped after the PET-CT. The PET-CT is necessary to screen the contralateral and the distant metastasis. And the further investigation than the PET-CT would indicate it in case of induction chemoradiotherapy. And the group in the case performed a VATS lobectomy, and I think it's was a good decision if we compare the indication of the consensus treatment proposal from the D'Amico group and others, VATS lobectomy consensus group that was published and based on the 20 years experience. Esther? I think Esther should be discussed this part.
Oh, I didn't know. Okay, we didn't discuss it before. So the adjuvant treatment part, well, I think we discussed it already in the poll just now, and there's no reason for N1 disease to give adjuvant radiotherapy, neither to give adjuvant concomitant chemoradiation. There's no evidence supporting this, and the data on the unexpected N2 have been very low as well. So there's an influence on regional recurrent rate, but not on overall survival. So there is no reason for radiotherapy because of no unexpected N2. and there is no reason for concomitant chemoradiation because there's no tumor inside you, at least as far as we know. And one of the interesting things ahead is I'm not sure that the Pacific 4 includes adjuvant immunotherapy. I know it is part of the combination with SABR, so with stereotactic radiotherapy. Then it is combined with durvalumab, a study called the Pacific 4 study, currently accruing patients, but I'm not aware of it being used only in the adjuvant setting, I have to say, Joseph. Maybe Solange knows more than we do, but I think it's only for concomitant chemoradiation, for stereotactic radiotherapy, and then it's combined and also giving in an adjuvant setting, but not after surgery. Okay.
Sorry, I'm on mute, that's right.
Okay, thank you very much. I think this was very clear. So I think the audience did actually quite well. The mediastinoscopy first, then the adjuvant treatment being chemotherapy. Let's have a look. Are there any questions for the experts from the audience on the first case?
May I ask Joseph what had happened if this patient had a worse lung function? So now this patient has been operated on, and in case the stations 4 and station 7 are negative, and this was the only station that we were presented, even though it turned out to be PN1. But if it had been only those lymph node stations and there was negative cytology, what would then be the stage when you would refer a patient for radiotherapy, to have stereotactic 3 times 18 gray?
So the lung function would be so wrong that the patient couldn't tolerate the surgery at all. Because
yes, and I mean, if you look at the Dutch data, also for those that could tolerate surgery, if they refuse to have surgery, the outcome rates are very good. Okay, so in that case, we should verify the lymph nodes. There are 2, but is your question that one? No, what would be, at which point? Because so we would only do an EBIS and ES, and if that's negative, as it was here,
if
we would
is not recommended for surgery, we have to verify the lymph nodes and the tumors. So regarding the tumor, it's too small, but maybe that the CT guided biopsy is an option. But otherwise, we could do a mediastinoscopy, or in experience case, VAMLA, TEMLA also, or videothoracoscopic procedure to verify the station on right side, the station 2, 4, 7, it's possible. And with this procedure, I think with a simple mediastinoscopy and with this SWAT procedure, we can reach all the lymph node that was in risk for metastasis on right side.
Yeah, and if the patient was like 80 and really had a bad lung function, so the only option that we have actually is really radiotherapy. Okay. How far would you then go with the invasive staging?
No. In that case, I don't think so. The SBRT can be applied in that case in some centers without tissue confirmation. But of course, it's a very selective case, and all the cases should be discussed individually. But in the final decision, if we wanted to treat the patient, I think the SBRT without histology can be accepted, discussed with the patient, of course, and the family.
Yeah.
Okay. In the meanwhile, we have some questions from the audience. The first question is about the adjuvant therapy. So the chemotherapy that was given as cisplatin-based. Can we comment on that? Should we do something else, something other, some other possibilities?
I can maybe take this one. So basically, we have been showing that adjuvant chemotherapy gives an absolute benefit of survival, probably in this patient category around 5% long term. And basically, I will discuss it also later on, only adjuvant chemo today has shown that, you can really improve the cure rate. So yes, you need adjuvant chemo, and yes, you need probably 4 cycles, knowing that in real life, probably only half of it can be really delivered across patient categories. But you have to aim at 4 cycles. The reason is that the meta-analyses have shown that the cumulative dose of platinum counts. And if you count around cisplatin, it should be probably more than 300 milligrams per square meter cumulative across the cycles you give. It would be ideal. In the same meta-analysis, though, it has been shown that the partner of the cisplatin can be of many types. Most frequently in Europe, we like vinorelbine. But when you travel to the US, they don't even know what vinorelbine is. It's a French thing, right? So in the US, they would give gemcitabine for squamous. They would give pemetrexed for non-squamous. They would also give carboplatin and paclitaxel, which in the meta-analysis are fine. So platinum-based, and I must say the decision of which agent is based on local standard and toxicity profile. Remember, cisplatin has a spectrum of toxicity. Paclitaxel had its spectrum of toxicity. So it's really more about guiding through toxicity pattern to assure that you might have compliance. There are 4 randomized trials adding immunotherapy in the adjuvant setting, adding to surgery plus chemo according to local standard of care. And these are ongoing with the first reading, I hope next year for the very first of them.
Okay, thank you. And the next question, back to the other experts. If the pulmonary function tests precluded lobectomy, what do you think would be the best, segmentectomy or non-surgical radiotherapy?
Segmentectomy is a possible, possible solution. It's not easy, lower lobe, but as I have seen on the CT, could be tried. Or basic, not one, a bisegmentectomy on in the lower lobe, 4 segments to remove, keep the segment 6. So there are some possibilities to do subsegment resection.
And I think the tumor is really located such that we can give 3 times 18 gray. So this could be an alternative for the patient. And the patient should just be consulted by both. So have a chat to the surgeon and the radiation oncologist.
Okay, thank you. Next question from our president-elect. Would you have proceeded to the same staging in case of a patient with borderline fitness? It's a bit the same. Would you have proceeded to mediastinoscopy first in case of a high risk patient? I think we already had a part of this. Then we go to the next question. Can you also discuss the advantages of mediastinal staging? So correct preoperative staging, possibility to give neoadjuvant therapy with more patients starting or undergoing the full chemotherapy, and excluding INTRIE disease from surgery.
I think the preoperative neoadjuvant treatment will be discussed on the basis of the next case. So I recommend to discuss together after the next presentation, okay, because that will be more detailed.
Okay, but then I suggest to go to the next case. I'll try to share my screen appropriately right now. So please tell me if it's not okay. This should be the second case. Everyone can see it. Okay. And this case is prepared by Dr. Hassan Batirel from Istanbul. He's our Director of Education and Secretary General-elect. The patient is a 48-year-old male, has no complaints, is a smoker of 1 to 2 packs a day for 25 years, so at least 25 pack years, routine occupational screening, and on the chest X-ray in the fall of 2019, this lesion was found. Physical status, no limitations. 85 kilograms for 1.70 meters, has a normal FEV1, otherwise healthy, and is an office worker in the factory. And the patient gets a CT scan. I'll show you this one. The bronchoscopy reveals a left lower lobe tumor inside the lower lobe bronchus, and the biopsy results are adenocarcinoma. There the lesion comes.
Mm-hmm.
And the patient also got a PET CT. This one is upside down, so that's from, we start from below. It's going now.
Mm-hmm.
And this is what we see. So the PET CT reports left lower lobe, 2 lesions actually, 3 centimeters and 1.5 centimeter, and the SUV max is 13 and 15 in the 2 lesions. Left lower lobe hilar lymph node, 2 centimeter in size and an SUV of 9. Increased uptake in stations number 7, being the subcarinal one, and 8, the paraesophageal one. Focal uptake in the left parotid gland, SUV of 9.1, and no uptake elsewhere. Question to the audience: what is the clinical stage? I'll let you vote. And I'll come back to the CT report, the PET CT report, that you can see it. C3 in 1, C4 in 2, C3 in 2, and C3 in 2 could be M0, MX, or M1. Take your time to have a look, and then you can vote. Almost 30 people voted, but we are 100, so we can have a lot more votes. CT3 and 2 is most popular, but it's not so clear if it is M0, MX, or M1. Another 5 seconds. Okay, about 40% of the people in the audience say it's a CT3 into MX. 30% says it's M1, and 20% says it's M0, and only a few people are saying it's a T3 in 1 or a T4 in 2. So I go on with the case, and then we can discuss this later. The clinical evaluation: a needle biopsy of the parotid lesion was negative for tumor involvement. The patient cannot decide on how to proceed and loses actually time, 1.5 months. Is admitted to the clinic after 1.5 months, and a cervical mediastinoscopy was performed. 4 right, 4 left are negative for tumor, and position 7, subcarinal node, was positive for adenocarcinoma. Next question: how do we proceed? Direct surgical resection and radical lymphadenectomy, curative chemoradiation, neoadjuvant chemoradiation followed by surgery, neoadjuvant chemotherapy followed by surgery. There again, very interesting. The expert can also see the votes?
No.
No?
Mm-mm.
In the poll section,
Wait.
you able to see it? So we see that right now, about half of the audience is saying neoadjuvant chemotherapy followed by surgery. But 1/3 is saying direct surgical resection and radical lymphadenectomy. Any comments on that from the experts?
Yes, I will explain.
I will comment on that on my discussion, right? It might be a matter of debate. I'm surprised we are really in ESTS because nobody speaks about curative chemoradiation, which in the US would be quite an option, right?
But not only in the US, I was one of the 2%.
Okay.
I think it's really based on the audience. It's very surgically driven and minded.
It is.
I'm not sure.
Okay, then we go on, and in this case, neoadjuvant chemotherapy was given. Paclitaxel, carboplatin, paclitaxel, 2 cycles. No regression in the primary tumor and a slight progression in the lymph nodes on PET-CT. There was a biomarker analysis from the tumor samples with a ROS1 mutation. So the next question, how to proceed again? And I'll let you vote again. What do we do now? Surgical resection, re-evaluation of the mediastinum with EBUS or VATS, because there was already mediastinoscopy. Continue systemic treatment with chemotherapy and add radiation to the treatment, or switch systemic treatment to crizotinib, TKI. Also here we have actually the 4 possibilities being used. One-third of the audience goes for surgical resection, 1/4 for re-evaluation of the mediastinum, and about 20% says continue chemotherapy, and another 20% switch to systemic therapy, systemic treatment to crizotinib. But not a lot of people are voting here. This is difficult. I give you another 15 seconds. Again, we don't know who voted. It's just to learn something. You cannot do anything wrong. No votes anymore. Okay. 42% wants to go for surgical resection, 24% for reevaluation, and the rest says continue chemo or switch systemic treatment. Okay, I'll proceed here. In this case, the crizotinib was started, so systemic therapy was switched. And there was a significant response on the CT scan, and I'll show you the scan. So left lower lobe, that's what we should look for. There it is, with a significant response. Okay, so again, we had the therapy with crizotinib. How would we proceed now? Would we eventually go for surgery? Would we go to re-evaluation again, continue the treatment with crizotinib, or add radiation to the treatment right now? Here, I think it's more clear. Surgeons in the audience are saying, okay, go for surgery right now, because we are already waiting for so long.
We will see.
Right, Jozsef?
I agree, but I have to explain the case.
Yeah.
Discuss.
Okay, so 3/4 of the audience are saying surgical resection, and the rest is more divided in between the other 3 possibilities. Okay, interesting. So we come back on that later.
Yeah.
Continue the treatment with crizotinib. This was what was chosen here in this case, and there was eventually a PET-CT evaluation a little bit further on, which shows a significant response with a partial regression on the primary lesion of 3 centimeters to 1.5 centimeters, and the SUV max was actually taken down from 14 to 3.6. There was no uptake in the mediastinum anymore, and a significant regression in the hilar lymph nodes. I'll show you that. The PET-CT and the PET is taken a little bit slower, but so indeed a significant response.
Mm-hmm.
Okay, now what? Surgery, crizotinib, or radiation therapy? And it goes in between surgery and crizotinib, indeed, because actually the crizotinib is doing well in this mutation. %60 surgery, 30% crizotinib in the audience, and 10% radiation therapy.
Mm-hmm.
Okay, we come back on that one as well. We actually went for surgery now. In this case, left anterior thoracotomy, a left lower lobectomy was performed with the radical lymph node dissection, an uneventful recovery, and discharge on the 5th postoperative day. Pathology report shows an adenocarcinoma of 2.1 by 2 by 1.3 centimeters, 30% viable cells remaining, no visceral pleural involvement, no intratumoral, perineural, or lymphovascular involvement. Lymph nodes actually all negative for tumor. Intrapulmonary lymph nodes also negative. So post-treatment pathological stage was YPT1B in 0 M0. Last question. What about adjuvant treatment? Continue with crizotinib, radiation therapy, chemotherapy, or no treatment and just follow up. And there it's between continue with crizotinib and no treatment at all, with the majority going for just follow up. Okay, this was the case. Dr. Botterell didn't say how this ended with the follow-up or not, and I think it's just because the patient was just operated. So I also don't know this. We can ask him within a minute. I'll stop sharing my screen, and I go to Dr. Peters for the discussion.
Thank you. I'll share my screen, and please let me know if you can see it well when it appears. Can you just confirm you can see it well?
That's great.
Okay, good. So I will take some of the points which were in the question. Of course, there's room for lots of discussion and debates in this case. Just a disclosure slide for clarity. So first of all, we have this patient, which by the way is a strange patient, because at the end we know that he suffers from an oncogene addicted non-small cell lung cancer, which is really mainly observed in never smoker patients. And this patient, as remember, had a heavy smoking history, which basically is not very common. So the question we always have to ask, and will ask in the future, is should we test for drivers in all non-squamous non-small cell lung cancer, stage 1, stage 2, and stage 3? Or should we do like we do today in stage 4 only? And the question is, maybe you can just select in never smokers, but this patient would have escaped from this kind of assessment. And of course, it's not a reliable criterion in stage 4. We still consider that that's more prevalent in never smokers, but it can happen also in smokers. So big question, open field of debate. And should we reflex test all non-squamous non-small cell lung cancer? About the staging, so as you have been seeing, it's a CT3CN2, if you want to be correct, which is a stage 3B. Interestingly, according to the HTNM classification, but was in most of the clinical trials we used to compare surgery or to compare to radiation, it was still a stage 3A in the 7th and 6th TNM classification. I would qualify this patient as having a stage 3B HTNM, but resectable disease, which is very important. So let's go into the question, how to proceed. So we have this stage 3B HTNM classification, direct surgical resection and radical lymphadenectomy. So basically, I'm a fan of evidence-based data. I'm writing all these guidelines. I would say no. I would say no, because when you have this very heterogeneous stage 3 disease, what is the main risk you suffer from is the risk of distant relapse, with 60 to 70% of the patient who will present with, at some point, metastasis from the disease. So the importance of really exposing your patients to chemo, and probably fast and with compliance, is very big. So I would say no. I will show more data later on. And of course, what is very important before deciding of chemo or resection is resection or radiation. And here we lost our radiation oncologist colleague, but there are now 3 randomized trials, which were not able to show, of course, it was for some of them all trial, but was not able to show a difference in terms of local strategy chosen between radiation and surgery. Of course, there was the differences in definition of a patient resectable, of a patient being fit. And of course, every country and region has its local standard preferences and surgical skills, right? So what defines resectability beyond what these skills are and local standards is very difficult to define. And would all this discussion be different in never smokers? So this is really a question which is really rational. In France, in Germany, in Switzerland, probably in many countries, surgery is preferred. But my experience from US is, as soon as you have a bulky disease or more than one station, radiation is preferred. So I said direct surgical resection, no. Corrective chemoradiation, why not? Why do I say why not? Because you have this ESMO guideline, and just go into this potentially resectable N2. It is our patient, and what we propose is to go into the multidisciplinary tumor board, and here still, even if in orange, I'm sure you would prefer a multimodality treatment with surgery, you still have a room for non-surgical radiochemotherapy plus radiochemotherapy treatment, chemoradiation treatment in this specific resectable N2. So it's about the tumor board. But keep in mind that we have moved the cursor a little bit since Pacific. You all know Pacific. Pacific is chemoradiation for stage 3. A very vague notion of chemoradiation, 50 grays, 2 cycles of chemo, and 1 year of durvalumab versus placebo. And at the ESMO meetings this year, we have been seeing the 4-year overall survival. And you would be impressed with me with these numbers of 4 years, 50% of the patients being alive, as you can see on the next slide, being stage 3A or being stage 3B, with a distribution half-half more or less. So really, very impressive data, you will agree, even being surgeons for many of you. So what else to do? I don't want to do direct resection. I open the field for chemorad, but maybe it's not the best audience to do that. So what's to do in neoadjuvant? Neoadjuvant chemoradiation, maybe? Neoadjuvant chemo only. So for neoadjuvant chemo radiation, I would say no, even if my US colleagues have been doing this for a while. And neoadjuvant chemo, I would say yes. So what about neoadjuvant treatment, particularly neoadjuvant chemo? So I don't want to go into the details of this table, but you know how much oncologists, medical oncologists like neoadjuvant strategies. Because first of all, you target this micrometastasis. Also because you can guide your adjuvant treatment, identify the patients who really respond and might benefit from surgery, facilitates translational study. And we don't like, of course, the small risk we have of potentially increasing surgical complication and having some rare, maybe 15%, 1/5 progression on the chemo. But basically, we really love neoadjuvant. Remember somehow that if you just give neoadjuvant chemo, major pathological responses in oncology, we call major pathological responses when you have less than 10% viable cells. It's an important new definition. With chemo only, it's quite rare, less than 20%. And complete responses in lung cancer, we are not melanoma or breast, are exceptionally rare, 0.2 to 4%, but just keep this in mind. So why do I say neoadjuvant chemo and not direct surgery? Because of these two very small trial, it was the old days where you could publish a New England Journal of Medicine with 60 patients, which doesn't happen anymore, but it was the old days, showing that neoadjuvant chemo was better than surgery up front. Since then, there were many meta-analyses, and this is probably the largest one across all stages, but with this very favorable hazard ratio in stage 3, in this meta-analysis of 0.84, which represents more or less 5 to 6% benefit, even 7% if you only focus on stage 2 and 3 by giving neoadjuvant chemo. So it has become a standard of care. And we would only address surgery in N2 if you give neoadjuvant chemo, at least in the guidelines and in my environment. What about neoadjuvant chemo rad? Well, here we have data. It's published in the Lancet. It was presented at the ESMO, at the ASCO meeting. It's a SAC trial. I'm the last, Nikki Pless is the first author. It was asking the question, stage 3A and 2, chemo rad followed by surgery versus chemo followed by surgery. Primary endpoint, event-free survival. Well, no change. Survival, no change. So what is the important conclusion we made on the SAC trial was to say, if you have one local treatment, which is optimally delivered, meaning a complete resection or a perfect radiation, it would be probably sufficient. And in this trial, complete resection was not benefiting from any radiation in the specific context of 3A and 2. So you might agree with me, neoadjuvant chemo only. Of course, we need to discuss about the future. Neoadjuvant chemo, well, we have all heard about neoadjuvant chemo IO maybe, and we like it because we had a fit host immune system as compared to post-surgical. We have a lots of neoantigen, we are able to prime an immune response, and we can, of course, do translational research. So neoadjuvant IO has been tested in many phase 1-2 trial with MPR, major pathological response rate, around 40%, or going up to 60-70% if you do neoadjuvant chemo IO. So very important kind of strategy. And we will know because there are 4 big phase 3 trials, which again combine IO and chemo in the neoadjuvant, with all the companies being involved, and these are the main pharma companies. And we will see after this huge number of patients have been recruited and met the events, probably in 2 years from now, the data about neoadjuvant chemo IO. So that might be the step for tomorrow. Okay, then suddenly you have neoadjuvant chemo, which I would have done, and no response. Indeed, it's not good. It's questioning, and by chance, a ROS1 mutation is found. So first of all, it's not only about ROS1, and keep in mind that us as a medical oncologist, we have for every mutation now a whole panel of potential treatments which are called targeted. They are more or less efficient, but for ROS1, all of these are very efficient and probably all more efficient than crizotinib. So there's a room for ongoing trials. And be sure that many of these compounds, particularly the new generation alectinib, for example, lorlatinib, osimertinib, are being assessed in the neoadjuvant setting, but it's still ongoing trials, very rare disease, but it's being done. So I'm still fine with the neoadjuvant CRISO. I would have done it because we don't have evidence, but it allows a good access to surgery. But what to do after this nice surgery? So the importance is still chemo and still 4 cycles of chemo, like I said before, and I'd like to convince you there's still no room for radiation. So still chemo, why? Look at the left-hand side. Again, only chemotherapy has been shown to be able to cure more patients, only chemo. TKI is nice. This is about osimertinib in EGFR mutated. TKI is nice because it gives a nice improvement in PFS, and even in the first-line setting is probably better than the old generation TKIs. However, nobody knows if you can cure anyone with a TKI. That's a matter of debate in the community because we have this adjuvant trial in EGFR mutated tumors, which is giving surgery to stage 1B to 3A, then giving standard of care chemo, be careful there is chemo here, then randomizing between osimertinib and placebo. And in that ADAURA trial, you will agree with me, the addition of osimertinib after surgery and chemo is amazing. Hazard ratio of 0.17 or 0.2 if you focus on all stages. However, still, this is disease-free survival. You still haven't shown you cure more patients. So still chemo has a role, and in that trial, chemo was given. This was not the question of the trial. What was nice in that trial was to show that most of the things you do, an important thing you do, I would say, is to prevent the emergence of brain mets after surgery in EGFR mutated patients. So I would say chemo, yes. Do you need to continue CRISO? I don't know. And this is a matter of debate. A CRISO is not going to the brain, so the answer is I don't know. And it's good to say this kind of things. Adjuvant radiation? Well, no. Since the ESMO meeting, N2 disease, 3A N2, thanks to the long art effort from the colleagues in France and internationally, Cécile Lepechou and colleagues, should not be delivered. It was a presidential session at the ESMO meeting because it changes the standard of care, because it makes us give up adjuvant radiation in completely resected N2 disease. The long art trial was relying on what we do also in the US. We give radiation to all N2 patients, even R0. There were data supporting it, particularly the SEER database, but in the most recent meta-analysis, the contrary was shown. So it was still a matter of debate. So long art is completely resected 3A N2 disease, receiving chemo like for standard of care in the adjuvant or in the neoadjuvant, and randomizing radiation versus no radiation. Be careful about the fact that they really use stringent R0 criteria like Rami Porta has defined, right? And you can see that despite a small benefit in DFS, the survival is absolutely unchanged. And DFS was, as you can see on the interval, not statistically significant. So this should be stopped. No adjuvant radiation. And we come back to the SAC trial. If you have one good local modality, one perfectly done, perfectly conducted local modality, this is enough, and you need to give chemo. And I think with that, I have covered most of the question with my opinions, of course, and I'm sure we can debate about them. Thank you.
Thank you very much. Dr. Batterel is saying that the patient is still followed, no problems so far.
Some light.
Okay.
The light.
There's another question. Is there any rationale for the adjuvant TK? Okay, this is something we already had. We don't know.
We don't know.
Any change in chemotherapy as it was progressing on the previous chemo? Instead of, suppose we didn't check for the ROS mutation, what could we do?
So it's my question to the surgeon here. Are you convinced that after 2 cycles of chemo with only a PET increase in the lymph node, are you absolutely convinced it is PD? Per RECIST, it wouldn't be PD. It would be something like SD. So I'm still first not convinced about the progression after 2 cycles, first thing, and then I would still challenge chemo. There might be in Europe the conviction that cisplatin might be slightly more efficient, and in patients with ROS or ALK disease, methotrexate would be very efficient. So I would still complete the chemo with at least 3 cycles of cisplatin methotrexate. But I don't know about the progression. What do you think, Jozsef? Are you convinced it was progressing?
Regarding the progression, so I think the decision of the team was good, but if nothing happened after the next neoadjuvant treatment and the lymph nodes would be removable, I think I would do a surgery.
Mm-hmm. Yeah.
But you would also reevaluate after 2 cycles, Jozsef, or after 4?
After 4.
Okay.
There are 2 ways to give this neoadjuvant chemo in Europe. With cisplatin, we sometimes give only 3 cycles, but we make very high dose cisplatin, 100 milligrams, or you give 4. But usually we reevaluate after 4 because there's a confusing picture after 2, right? Also because sometimes of the interval between the first assessment and the start of chemo. So I would do 4.
Okay. I will try to invite Dr. Batterel on the stage because he wants to comment on his case. Let's have a look where I can find him. Getting ready. There he is.
Hello, good evening.
Hassan, welcome.
Oh, this patient was very interesting. We wouldn't expect that too, but the patient was being treated in another center in Anatolia, and the oncologist decided, actually the patient came to Istanbul for surgery. We did the mediastinoscopy, and actually in the mediastinoscopy, the subchondral lymph node was very hard, and there was most likely, and the pathologist said there was extracapsular involvement most likely in the subchondral lymph node. And then there was possibility that it was really stuck to the bronchus. So I was not really expecting this patient to give an excellent response and to go for surgery. I was thinking that the patient would really progress and drop out of surgical option. But eventually, I honestly was not very familiar with the TKI inhibitor in terms of, you know, I'm aware of the drug, but not as an option in such a case. And that was the decision by the oncologist. And eventually, I was amazed with the clearance of the tumor in the lymph nodes. And the reason we did this case open was because there was extracapsular involvement, so bronchus might have been involved. So we had to take out 4L and really make a good clearance of the subchondral area. So I was not sure, we do a lot of VETs, but I was not 100% sure we would do it correctly. So we just went through it, and it was a very fast surgery. I mean, it was not very difficult, honestly.
Mm-hmm. No, you have to keep in mind.
Was good, but you don't know if the patient will metastasize to his brain in the first year or in 1.5 years. We'll see.
That's what we like with TKIs. The response is deep, fast, meaning deep, frequent, like 70% response rate, and fast. Usually at the first assessment you do in trials, it was 6, even 9 weeks. You see the response already, and very often the deepest response are 9 weeks. So it's very satisfactory. But to which extent it's really a cure, it's really the matter of debate. You know, this osimertinib for 3 years in adjuvant is really a topic of discussion, not only about rational, but also about how sustainability, right, of a system which would give 3 years of zimertinib to all EGFR resected patients. So it's a real matter of debate. Does it mean cure?
You have a point, obviously. We'll see. I will inform about the outcome of the patient in the coming years.
Did you continue crizo, or did you stop crizo? Did you continue crizotinib?
I need to check that, because the patient was very happy with the surgical result. Went back, and I told him to consult with the oncologist again, but I'm not sure if he's getting any adjuvant chemo or crizotinib.
Let us know.
I will check. Okay. Thanks for joining. Thank you for inviting, Lieven.
Okay, no problem. Thank you, Hassan. Any other questions from the audience? I think we are 10 past 7. It has been a very interesting journey for me as well. It's the first time we do this very interactively. I know all the buttons right now, I think. If not, yes, there's one extra question. Let's end with this one. As neoadjuvant chemotherapy gives a clue for the response assessment in neoadjuvant chemotherapy setting, in cases where patient is not responding to neoadjuvant chemotherapy, yes, is TKI not a good option to induce a response before local modality in view of gene mutation is present?
It is probably. It's a very good question, and that's what the trials are now attempting to do. It can help for a full resection, which we all know is very important for the outcome, right? But to which extent? We have one adjuvant trial of old generation, first generation EGFR TKIs versus observation by Chinese groups, right? The Xitong trial, which unfortunately was showing that with this TKI, what you do mainly is to delay the relapse. So it means that you can also catch up the same patients afterward with the TKIs when they become metastatic, and you have the same survival at the end. But probably the most potent TKI you have, and if really you can perform a nice surgery, it's already a factor for long-term survivorship. But I wouldn't feel the courage today to skip chemotherapy, because chemotherapy in breast, in GI, in lung, is something which can sterilize a body from cancer cells. And we don't know that about TKI. So I like the neoadjuvant because it allows for surgery, but still keep the chemo yet.
Okay, thank you. We will conclude with this. Today was a great webinar again. So the first one in this multidisciplinary session or setting. We'll certainly do that again in the future. We were about 100 live attendees, and many other ones will look afterwards. I think we had many interactions, and on behalf of the ESTS Learning Affairs Committee, I would like to thank our expert panel, Professor Solange Peters, Professor Esther Troost, and Professor Jozsef Furak for this excellent webinar today. Also, Nuria and Hassan for preparing the cases. And you, of course, the audience, for your interest and your interaction. Thanks again, stay safe, and I hope to see you again in November with Dr. Frank Detterbeck on the role of neoadjuvant and adjuvant treatments for thymomas. See you next month.
Thanks a lot. Bye-bye.
Thank you very much. Bye.